Good morning. My name is Jamie Wasilowski, and I'm the President and CEO of Memphis Healthcare Ministries. Thank you all so much for joining us this morning for what we hope is a timely and meaningful discussion on an issue that truly defines health equity. That's providing affordable and accessible healthcare coverage to over 1 million uninsured working Texans who are living at or below the federal poverty level. These Texans likely have not visited a doctor for wellness or preventive care in the last few years, unless it's in a local emergency room. And if they had seen a doctor and learned they were battling a serious chronic or fatal disease, there would likely be no type of program that would ensure they receive specialized treatment or hospital care. These Texans we speak of today as we deliberate an opportunity for the state to invest in the health of its residents. Methodist Healthcare Ministries understands that health and wellness begin long before individuals seek clinical care, and we prioritize the importance of the social determinants of health, access to quality resources and care, recognizing these are the driving factors that foster resilient families and thriving communities. Our organization has been around for over 25 years now. We were created as a result of the vision of the United Methodist Church and a willing partner, HCA Healthcare, one of the nation's leading providers of healthcare services. The impact of the COVID-19 epidemic on the world, our country, and this state has been devastatingly fatal and life-changing for so many families, some much more than others. As of today, Texas is reporting 2.3 million confirmed positive cases of the coronavirus and the loss of 43,000 friends, family, and neighbors. The lack of access to a physician, to medication, and in some of our counties, even a hospital bed has never been more important in helping us survive this deadly virus. Today, Texas remains one of 12 states that has not expanded Medicaid coverage beyond pregnant moms, children, our elderly, and disabled. This, despite leading the country with 18.4% uninsured adults and 12.7% children without coverage. You know, we pride ourselves in leading one of the strongest economies in the country. In fact, we have the 10th largest economy in the world based on GDP. But like any powerful organization, we know that we're only as good as our most valuable asset, and that's our people. And the future of this state depends on growing a healthy, educated, and sustainable workforce. Today, Methodist Healthcare Ministries welcomes the opportunity to convene a discussion among state policymakers, philanthropists, and research organizations, all who are committed to the well-being of this state, its communities and families, so that every single Texan has an opportunity to lead a full and productive life. Again, on behalf of the Methodist Healthcare Ministries, we thank you for joining us today and hope this discussion elicits more good debate and thoughtful actions to bring about meaningful change for all Texans. With that, I will turn it over to Evan Smith, the well-known CEO of the Texas Tribune and our moderator for today's discussion. Evan?
Jamie, thank you very much. To you, Jamie, to my friend Chris Yanis, and everybody at Methodist Healthcare Ministries, I want to thank you so much for having me today. It's my pleasure to get to lead this portion of the program, to talk to really smart people about an important issue, and that is the future of healthcare in Texas. And with that, we're going to have a conversation first with two public servants, people who are contributing to the public dialogue. They're public citizens, they're public intellectuals, and they have put themselves in the position of helping think about the policy choices that we have on the road ahead. Tom Luce, first, is the founder and chairman of Texas 2036, a 4-year-old nonprofit that takes as its mission marshaling data and research in service to the idea that Texas can be the best place to live and do business through its bicentennial and beyond. And in case you need some education in what our bicentennial is or when it is, that will be in 2036, and that is 15 years from today as we sit here. Tom is a native of Dallas. He has undergraduate law degrees from Southern Methodist University. Once upon a time, he founded and was the managing partner of the Hughes and Luce law firm. He's also been Assistant U.S. Secretary of Education, founding president of the Meadows Mental Health Policy Institute, founding CEO of the National Math and Science Initiative. I could go on. Also joining us today is Charles Miller. Charles is Texas 2036's Senior Policy Advisor. He previously served for 2 legislative sessions as a budget advisor for Governor Greg Abbott. He is a native of Ohio and a graduate of the University of Notre Dame and University of Texas School of Law. Charles, Tom, welcome. Good to have you both with us today.
Thank you, Evan.
Thanks. Glad to be here.
Good to see you both. Tom, I always begin conversations with you before a group like this one, an august group like this one, not assuming that people know what Texas 2036 is or why. So let's make sure everybody on this call knows why this organization was formed and specifically why healthcare is a focus of the organization and of yours.
Well, it was formed because I was concerned about the future of Texas, to make it real simple. And that is, could we remain a dynamic, growing place, deal with the issues of growth?
Yep.
Could we sustain our progress? Could we increase the progress for everybody with sufficient amount of fairness and equity? And I had learned through the hard way that most public issues were interconnected. That is to say, a well-educated person was a healthy person was a well-educated person.
Right.
And I, like everybody else, had advocated within silos for this road project or this water project or this education project, and really found it was all interconnected. So we decided also that Texas was changing politically. We needed a bipartisan, data-driven organization that would put facts in the middle of the discussion, data in the middle of the discussion, and deal only with major problems of education, health, infrastructure, natural resources, justice and safety, and government performance. And we'd leave the other issues to everybody else. We wanted to focus on the main things.
Right. Tom, you and I are both old enough to remember when we thought government solved problems.
Right.
And the reality is that you've had to take the conversation about these big issues and about the future of the state out of the purview, out of the hands of government into a private organization. Why is that?
Well, it's the changing nature of politics. You know, I used to say long-term planning for state government was the next November election. Now it's maybe the next tweet or the next, redistricting battle or the next social media moment.
Right.
So we really think it's important when you're dealing with these big issues. You don't turn the Queen Mary overnight. We're not going to change the healthcare system overnight.
Right.
And so we're not going to change education overnight. And so Medicaid is a perfect example. We felt strongly that if we were really honest with ourselves about human capital as the future of our state, we were going to run out of healthy, workable, working people by 2036.
Yep.
We were at full employment prior to COVID. We were going to run out of healthy, able-bodied, well-educated people by 2036. It's that simple. And yet nobody had taken a realistic look at Medicaid for 12 years because it basically has been involved in a holy war between the two parties for 12 years. And everybody's feet got planted in cement, and nobody had looked at the facts in 12 years. So we said, look, we need an organization that will lay out all of the options for dealing with the fact that we now are 50th out of 50 states in the number of uninsured people. That's not something we want to leave the nation in.
And of course, have been there for some time. You know, a state that loves to be first and best at everything is dead last, as you point out, in the health insurance. Tom, let me just observe, for an old guy, I think blaming everything on social media is very relatable. So thank you for doing that. It is the fault of Twitter, of course. Charles, you have developed a tool at Texas 2036 that you want to show us. This is the Health Coverage Policy Explorer. This allows Texans to explore the cost and benefits of more than 500 different possible policy combination scenarios available to state lawmakers during the 87th session to address the uninsured rate in Texas. How did you build this tool? What's in it?
Well, let me just share my screen and show you the tool. It's available online on our website. Anyone can go access it and play around with it.
And that's texas2036.org, right?
That's correct.
Yeah.
So we actually, let me just flash for our viewers here. Here are those URLs that you can go access that tool yourself. I'll put those up again at the end of this program.
Yeah.
And before we get further, Evan, I want to wish you interviewers a happy Texas Independence Day. It's Texas 2036. I think it's appropriate we're doing this on our Independence Day in Texas.
Right.
So here's our tool. We put this together. We went out and hired a great team of experts with knowledge in both the Medicaid side of things as well as on the affordable care side of things, because those are the two areas that we identified that were federal funding streams that Texas could leverage to increase the number of insured Texans. So let me tell you a little bit about the team we went out and hired. We were able to get Lisa Caruth and Stephanie Muth. Lisa Caruth is a former chief financial officer and forecasting director for the HHSC agency in Texas. It's the agency that oversees Medicaid. And Stephanie was a former state Medicaid program director. They really know the ins and outs of the program, how to identify all the impacts in various ways that programs and populations would shift between. On the Affordable Care Act side, we went out and hired some nationally recognized actuaries, Greg Phan, Daniel Cruz. When you get into the ACA markets, there's this thing called price-linked subsidies that make these markets behave in weird ways. These guys really understand it and know all the ins and outs of it. We're also able to work with Cheryl Gardner. She's a former state exchange director and has recently been helping states submit what are called 1332 waivers. Those are requests to the federal government to help make changes to those ACA individual marketplaces. We also went out and got some data visualization experts to take all of our nerdy spreadsheets and put them into this form that's a little bit easier to view. So on the tool over here, we can see here's our programs that we model out over here. I'll get to those in a bit, but just want to show what we're going to see here. The idea was to model the costs and impacts of these various policies in terms of net state budget impacts to Texas and the number of newly insured people. Now, a lot of times when we look at these various proposals, they're looked at in a siloed way. And so we see how many people would be covered by a particular policy, but we don't always see the impacts from, well, they were previously insured by one policy and now they're shifting over. So we're talking about the net number of newly insured people here. We also have the net state cost, the amount of new federal dollars that would be coming into the state on an annual basis, as well as the remaining number of uninsured. Now, you see that these numbers are for 2025. We thought that that was an appropriate time for when we would have gotten past our startup costs, have enrollment ramped up, and would be a really good, accurate go-forward number. Mm-hmm. Up here, we see our baseline uninsured rate. And again, that's 2025 estimated. And then this bold number here is going to change as we see the impacts of these policies. So once you select it, this number will change to show our projected uninsured rate. Yep. We also have a estimate of a fiscal note for the viewers who may not know what that is. That's the cost if legislature were to put together a bill and it were to be scored. That's how much budget impact it would have over the upcoming budget that they're putting forward for this legislative cycle. And then we have a value number here, and this is the net cost to the state per newly enrolled person. And that's basically taken by getting this net state cost and dividing it by the number of newly insured people. Now, before we go into these policy scenarios, I'm going to tell you three things that I want you to take away today. The first is that on the Medicaid side, the 90% match matters a lot. If we are able to qualify for a 90% match on our Medicaid program, it allows us to cover a lot of people for very little cost, maybe even a savings. And the 90% match is the rate at which the federal government will help pay for the program. Right now, our Medicaid programs are paid at a 60% match, where the federal government pays 60% of the cost, the state pays 40%. If we are to do various programs to change our Medicaid program and increase those eligibility thresholds, we can get and qualify for a 90% match. That allows us to pay only 10% of the cost of those, but it also allows us to shift some populations over from the current 60% spending, or in some cases 100% state spending, over to that 90% match and see some savings. We've identified those in a lengthy methodology document that you can download here, but we also tried to pull them out so that you can see the budget impacts, costs, offset, revenue changes. And we found that staff members have been really interested in this and looking at these items and being able to identify exactly where in the budget we might realize some of these. The second thing we're going to see is that there are things that we can do to improve our ACA marketplace that'll cost the state almost nothing and have real impacts to the number of people who'd be able to afford insurance. And then the last thing that we're going to see is that an all of the above strategy can work for Texas. We can cover almost 1 million people for a net state savings at the end of the day, but that coverage is not going to be a silver bullet. We're still going to see an uninsured rate that's pretty high, I think around 14%. Right. We'll see when we do all these options. And we also need, therefore, to focus on issues of access and affordability. So with that, let's start with that 90% match number. What we've modeled out here are three scenarios where we would expand the existing Medicaid program to new populations. One is a full expansion. We'd increase that income eligibility threshold from right now, it's basically 0% if you are considered an able-bodied adult, or 14% of the federal poverty level if you have kids. And really that 14%, that's about $3,500 a year if you're a family of four. So it's almost nothing. That would expand it up to 138%, which for an individual is about $17,500 a year. So if we increase that, we'll see this baseline assumption, we'd be able to cover about 720,000 newly insured people at a net state cost of $1.3 million, bringing in about $4.3 billion per year of federal money, but we'd still have that uninsured of about 4.8 million. Now, this value number here is under $2 per person per year. And our estimated fiscal note, taking into account some startup costs and not quite fully ramped up enrollment, is about 5.9 million. One of the great things about this tool is we do pull out some assumptions. When you get into the weeds with the experts, they'll ask you, well, what's your take-up rate? What's your per member per month cost? You can slide these around if you disagree with ours, and you'll see the impact to the tool. And that's kind of more of an expert mode. If you've got assumptions that disagree with what our experts said, and there is a reasonable range of disagreement that can occur, you can change that, and we can have a conversation about what is reasonable. To see the impact of this 90% match, though, remember these two numbers: 720,000 newly insured people, net state cost of 1.3 million, value number of $1.30. We'll do this partial expansion. Now, this reduces the income eligibility threshold down to 100% of the federal poverty level. That's about $12,500 for an individual. By doing so, we lose that 90% federal match. In order to obtain that, you have to expand it up to that 138%. It's a magic number. And when we do this, we lose about 220,000 people that would gain coverage, but our net state cost balloons up. We're up to about 760 million. That value number goes up to about $1,500 per person per year. So that 90% match matters a lot. That being said, there are other ways to qualify for that 90% match. We don't have to do just a straight Medicaid expansion. We could also change the program and do a Medicaid program improvements through an 1115 waiver. This is what Indiana did under Governor Mike Pence. They submitted an 1115 waiver to the Obama administration that included some personal responsibility components, things like copays, premiums, healthy behavior improvements, and more controversially, work requirements. We've modeled out what those sorts of things would have as an impact to the state program. And what we see is that, yes, we do lose a little bit of our coverage. We go down from 720,000 to about 650,000. And we actually are able to save the state money if we do things like this. Those work requirements I mentioned, they are controversial. We allow you to model this with or without them. That's a toggle that you can choose. And you can see here that removing them does increase the number of people you cover. It reduces those savings a bit as well. So that 90% match is really what enables us to cover people on the Medicaid program in a more affordable way. But you don't have to simply expand Medicaid. You can also change and improve it to design it in a way that improves outcomes. So that's our takeaway there. On the Affordable Care Act side, there are two things the state could do relatively easily to increase the number of people that are covered and save the state money. The first thing is we can run our own exchange. Right now, our insurers are sending about $200 million to the federal government to run that healthcare.gov website. That might have made sense when it first came out. It was a little bit more complicated, but it's off-the-shelf software now. We can do this our own. Other states have figured this out. They're doing this for a lot cheaper than what we're currently paying the federal government. What we show is that by doing so, we could bring back that money that we're sending to the federal government. We can save the state money. And because there'd be a little bit more of a Texas control of how we're reaching out to people, we could see some slight increases in the number of people that are covered. We could combine this with a focused rate review. And the focused rate review is a complicated idea, but it's really easy to implement. We've talked with the department. They're already reviewing rates, but they're not enforcing them. If we take back over enforcement to make sure that those premiums are put together in an actuarially sound manner, we could increase the amount of federal money coming to the state by over $1 billion through those subsidies. And by bringing in that extra $1 billion of subsidies, we're able to decrease the net premiums for people buying insurance on the exchange. There's some complicated dynamics there. If we have some questions about that, I'm happy to get into that later. But just know that we can increase coverage by about 275,000 people on the exchange at no cost to the state, simply by doing these two things. Now, the last thing we'll see is that we can do an all of the above strategy. We can do a Medicaid improvement program. We can do those things that I talked about on the ACA. And then we can also submit a 1332 waiver. These are more complex. We've developed one that's called a subsidy optimization model. This is taking the existing subsidies and reallocating them in a way that's more efficient. It's designed to get younger and healthier people to sign up more so right now. Right now, the risk pool in the ACA is overwhelmingly older and less healthy individuals, which makes it more expensive. It makes it tougher for people to be able to afford this. If we reallocate those subsidies in a more efficient way, we'll actually see a lot more younger and healthy people sign up, which is great. Not only do we get an initial boost of the number of people enrolled, we make that risk pool healthier. And so it creates a long-term virtuous cycle that can hopefully reverse that death spiral that we have seen in the ACA markets. What we see is that when we do all of the above, we can cover just under 1 million new people at a net state savings of about $70 million a year, bringing in about $5 billion in federal money each year. And yes, we still do have about 4.5 million people who are uninsured. I mentioned earlier, even doing all the above, we still have an uninsured rate of about 14.6%. That's important, though. We know that even if you have insurance, you're not always able to access care because you don't necessarily have a doctor near you. And we also know that over 50% of Texans with insurance have delayed care in the last year due to cost. So it's important to address these issues of access and affordability alongside coverage.
Evan, let me stop you right there. I mean, just look at that set of numbers. You know, I've lost all my accounting skills, although I majored in accounting in college. But we can add basically 1 million people with insurance.
Right.
We save money and we get $5 billion of federal funds into the till. That's pretty basic math to me.
Right. But as you know, Tom, this is not about math. It's about politics. And this is what I want to ask the two of you. You know, you could say, let's take the politics out of healthcare, but taking the politics out of healthcare is like taking the calories out of fried chicken. Right. I mean, we know the difficulty of this, and this is a heavily politicized issue. And Charles, I want to direct this specifically to you. On the website, you come right out and say, and I realize you're presenting different scenarios for us today, and there are different ways to configure the numbers on the website so that different scenarios come up depending upon exactly what brand of politics or what brand of math you want to factor in here. But you come right out and say on the Texas 2036 website, to optimize coverage and cost, the Healthcare Policy Explorer demonstrates that Texas elected officials need to access the enhanced 90% federal matching funds. Need to. You are making the case for Medicaid expansion. Let's come right out and say it. Does your old boss, Governor Abbott, know you've gone rogue?
What we're making the case for is the financial case for accessing the 90% match, and that doesn't have to be done through Medicaid expansion. One of the big contentions is how the Medicaid program is currently being run and operated. Right. And there are some individuals who have legitimate concerns about how that currently exists, that it may create disincentives to work, et cetera. There are ways that we can create and reinvent the Medicaid program to improve those issues by modeling what other states have done, like Indiana, to create some of those improvements that will make the Medicaid program better. Once we're able to bring people together and say that we can redesign that Medicaid program to be something we want, while also requesting the federal government to access that 90% match, that's how we're able to do so affordably.
But hasn't that been the conversation for years, though, Charles? Is, you know, there's been a discussion of a Texas way. Where is the Texas way? Can we take control of this conversation? But there seemed to be a reluctance at the state level even to enter into a conversation with the federal government about how to do that.
But I'm telling you, Evan, I think the circumstances have changed. Look at all the problems that we face post-COVID recovery. Look at all the problems we face with regard to the electrical grid. Where are we going to get the money to pay for all these things? I think the dynamics have changed, and I think the politics have changed. We'll find out.
We will find out.
And you're right historically, but I believe the circumstances have changed as to where the state is.
Charles, go ahead, please.
I think that there was a legitimate concern in years past that the court might strike down the Affordable Care Act. And if the court struck that down, that 90% match was going to go away, and Texas could have been left holding the bag. That was a legitimate fear. There were real cases out there. I think the last real case against it was heard by the Supreme Court in November. And frankly, it was kind of laughed out by the justices. We don't see any realistic chance that the 90% match is going to be thrown out. And I think that that's created a change condition. This is our go forward for the future. And I think people are starting to acknowledge that.
Charles and Tom, you say on materials associated with this Explorer, even under the most optimistic, and Charles has referred to this a couple times this morning, even under the most optimistic scenarios, under the policies we've modeled, nearly 14% of Texans would remain uninsured. Increasing insurance coverage is an important tactic, but we need to do more to help increase healthcare affordability and access. What does that mean exactly? What more do we need to do beyond this conversation around 90%?
So the 90% is a real help to get people coverage. That makes people's care affordable for those people who receive Medicaid coverage.
Right.
But for the 80% of Texans that have insurance right now, they're not able to afford care either. They've been facing higher deductibles. They've been facing higher out-of-pocket costs because prices are out of control. And a big part of the problem is we don't know what prices are. They are not transparent. So we need to make sure that prices are transparent so that both patients, but also institutional purchasers of insurance, of healthcare, like employers who have self-funded plans, which is the way that most people get their care, can figure out what provides the best value. We hear a lot of discussion about value-based care.
Right.
But the way we decide value is by looking at what does it cost and what do you get. Right now, we don't know what it costs because those prices aren't transparent.
Right.
Price transparency is a huge first step. It's not a magic bullet either, but it is a huge first step to actually helping people being able to determine value in care. On the access side, we need to make sure that we have enough medical providers for people. That means improving telehealth. We've seen HB4 is going to be a priority on the House side. That's great. We're going to see increased telehealth access. We also need to look at other things like making sure perhaps that nurse practitioners are able to practice independently in shortage areas so that we increase the amount of providers who are available to help people.
Tom, we need to move on to our next panel, but I want to ask you a last question here, and that is, you've been around long as I have, and being around a long time often equates to cynicism about the ability to get things done. This is a moment when we really are at a point of crisis on healthcare. And as you point out, with all the costs associated with the coronavirus and what we've come to refer to as Snowvid, the storm of the last 2 weeks, which will be the most expensive natural disaster in the history of the state, do we really have the stomach? Do we really have the bandwidth? And do we really have the budget to deal with this problem?
I honestly believe we do, and that's the reason why we decided to charge to the top of the mountain.
Yeah.
And we've laid out the case. You have champions who have picked up the case, like Nathan Johnson, who you're going to talk to in a minute. But we're also seeing a lot of interest. We got a lot of calls from members of both parties about our tool. We're carrying on lots of conversations one-on-one with people. I'm seeing an enormous amount of interest as the awareness of the financial issues that the state faces.
Yeah.
And let's face it, Evan, we're not reluctant about taking federal money for transportation or the CARES Act or education. And we shouldn't be hesitant about taking our money from the federal government for health.
Especially when it's our money, and if we don't take it, it's paying for the healthcare in some other state, right?
38 other states.
38 other states. All right. Well, Charles Miller, Tom Luce, good to see you both. Look forward to being in person again when we're on the other side of whatever this is. And be well, please. Well, now let me introduce our second conversation of the morning and three distinguished panelists. First, Dr. Vivian Ho, who is the James A. Baker III Institute Chair in Health Economics and the Director of the Center for Health and Biosciences at Rice University's Baker Institute of Public Policy. She's also a professor in the Department of Economics at Rice and a professor in the Department of Medicine at Baylor College of Medicine. Her research examines the effects of economic incentives and regulations on the quality and costs of healthcare. She's a native of Montreal, has an undergraduate degree from Harvard University, a graduate diploma from the Australian National University, and a PhD from Stanford University. She will be joined today by State Senator Nathan Johnson, Democrat of Dallas, first elected to his District 16 seat in 2018, his first run for office. In the 87th session, he's vice chair of the Administration Committee of the Senate, sits on the Business and Commerce, Jurisprudence, and Water, Agriculture, and Rural Affairs committees, as well as the Special Committee on Redistricting. He is a native of Fort Worth, graduate of the University of Arizona and the University of Texas School of Law. Finally, Dr. Ray Perryman, president and CEO of the Perryman Group, an economic research and analysis firm based in Waco that is counted among its more than 2,500 clients, 2/3 of the Global 25, over half of the Fortune 100, the 12 largest tech firms in the world, 10 U.S. cabinet departments, the 6 largest energy companies in the U.S., and the 5 largest U.S. banking institutions. He is born in Tyler. He has an undergraduate degree from Baylor University and a PhD from Rice. Dr. Ho, let me begin with you, because as you heard Tom Luce talk about the economics and Charles Miller talk about the economics of healthcare in the state of Texas, leaving aside the case politically, leaving aside the question of need, we have a really extraordinary situation as far as the cost of healthcare in Texas at the moment. Do we not? Give us an overview of the problem we're trying to solve right now.
Well, we've had healthcare costs in Texas and in the entire nation growing faster than the rate of growth of GDP for just about decades now. And so that's just a compounding problem. And we have hospital costs that are a third of all healthcare expenditures that have been growing increasingly because of increase in market concentration amongst the largest providers. So they can negotiate very high costs. They're not the only people to blame. Everyone knows about rising drug costs. And we have a concern, it seems, that the employers, to me, my concern is the employers have not pushed back on employer-sponsored healthcare, rising healthcare costs as much as they should, because those are our largest costs. Yeah. And then those employers are just passing the costs on to their workers, which is why workers never see increases in their wages that are matching what's going on in terms of our growth. So there's a lot of blame to go around everywhere. I agree with Charles Miller that transparency is part of the problem, but it's only part of it. And there are many different things that we need to go after.
Senator Johnson, if you just make the argument on the basis of economics, that is appealing to many people in the legislature for whom the politics of healthcare may be more complicated. But the reality is there's a need. You heard some statistics that Tom and Charles threw around. Pre-pandemic, Texas was at 18.4% uninsured, literally double the national average of 9.2%. And we assume that the pandemic has worsened the situation since so many people's insurance is tied to their employment, and we have more than 4 million Texans who've lost their jobs over the last year. Make the case on the basis of need, leaving the economics aside and the politics aside.
Absolutely. Thanks. COVID has made a lot more people vulnerable, but it hasn't just increased the number of people that lack health insurance. It's changed who they are. It has increased the level of empathy, I think, within the state to realize that it's not just those people who you don't know who lack health insurance, it's the people who you do know that lack health insurance. So we've got a lot more attention on the problem to begin with. We also have to recognize that our healthcare system is so expensive. These people do not have healthcare. And if they do not have healthcare, they're going to go the only place they can get it, which is the emergency room, which, by the way, is crowding the rest of us out, while it costs about 6 times as much to take care of people as it otherwise would. We've got people who have really very treatable conditions, very inexpensively, who wind up in an acute state of ill health that becomes expensive. It prevents them from going to work. It prevents them from taking their kids to school. The need is profound right now, and it's getting worse every day.
Senator Johnson, let me stay with you for a second, because it seems to me that even if you are willing to look past the rising numbers of Texans generally who don't have access to health insurance, let's just focus on the most vulnerable Texans. Let's talk about children, for instance, right? You heard Charles also say that 12.7%, we have an uninsured rate among children in Texas of 12.7%. That is against 5.7% nationally. And that, again, is pre-pandemic. In 2019, the 2 U.S. counties with the highest number of uninsured children were Harris County and Dallas County, not just in Texas, but in the country. And in fact, the 5 U.S. counties with the highest percentage of uninsured children were in Texas: Dallas, Hidalgo, Harris, El Paso, and Travis. It seems extraordinary to me that even if we're not willing to solve the problem in the main, children, the most vulnerable, who are not responsible for this, who didn't cause this, that seems to be a problem that we should all be able to get behind, right?
Yeah, and it's unforgivable, and we cannot keep it. But what we need to understand, as Tom was saying, all things are connected. All things are connected, and we do find that when adults lack health insurance, their children are more likely to be able to avail themselves, because they can't avail themselves. Their parents have to sign them up. And what we find is that when we get adults health insurance coverage, they are more likely to sign their kids up for health insurance coverage. So these things are connected.
Yeah. Hey, Dr. Perryman, I was going to ask you to tell us what the impact would be if we did move to some kind of Medicaid expansion. But I confess I was always the kid who read ahead to the last chapter to see how the book ended. So I read the report that you published on December 14th of last year. You estimate that the economic effects for the 2022-23 biennium would include gains of 45 billion in gross product, 29 billion in personal income, and almost 461,000 job years of employment over the biennium. Net total dynamic fiscal benefits during the biennium would be 2.5 billion to the state and 2 billion to local government entities across Texas. What am I missing here? This seems like a good deal.
Well, it is a good deal, and it's been a good deal since its inception. Again, there's ways we can do it to hope we could put some of the politics aside. But the bottom line is what our analysis does is it takes a lot of the things that are in the tool that Charles was demonstrating, which is excellent, by the way. One thing about it, I'm one of the nerds that plays with the assumptions. Yeah. It's very robust. I mean, we get benefits of this with any reasonable range of assumptions. It's a good deal for Texas, any way you do it. But we take that and go beyond that, look at some other things, and some of them were the kind of things Jamie was talking about before. When you have access to health care, you get health care earlier in the cycle, and so you don't become a chronic case when it's unnecessary. If you have health care, you are more productive. You have a longer lifespan. All of these things have been done for you. Perform better in school, and that affects your lifetime earnings. I mean, there's all of these things that come into play in part of a big social complex that healthcare is a small piece of, but an absolutely critical piece of going forward. And so what we try to do is say, when you factor all of those things in and go beyond the sheer math, which just the basic math, like in Charles's tool, shows it's a no-brainer. But so if you put everything else in, it becomes even more of a no-brainer. There may even be a new provision in the new stimulus package that makes it even more of a no-brainer. We'll see how that plays out over the next week or so.
Dr. Perryman, you heard, I think Jamie at the very beginning of this hour refer to the fact that Texas is one of 12 states that have not adopted some kind of expanded Medicaid.
Right.
8 of those, by the way, are in the South. I think that's really interesting, that this has actually become, as much as anything, a regional problem, right? Have you done any work looking at what the economic impact has been in other states? I'm assuming that you're not looking at Texas in a vacuum, but that you're modeling in part on the basis of what the real effects have been elsewhere.
That's exactly right. We are, and I want to give a brief shout out to Dr. Laura Daig at the Bush School at A&M. She's done a very, very deep dive, county by county, on how this is, looking at exactly what happened in other states in similar situations and how that played into it. And that was some core inputs to everything we did. But we've helped several states along the way as they tried to set up programs and run programs. We've assessed their programs, and fortunately for us now, when we first started working on this, back when it first came out, we were kind of flying blind, saying, how would this work? We now have the advantage of using what's happened in those other states to help us understand. Another, a very good example of that, some very good work's been done by the Kaiser Foundation on rural hospitals. I mean, if you have Medicaid expansion, your rural hospitals are more viable, and that's a critical part of the Texas medical complex. So there's all sorts of things that play into this.
Dr. Ho, you made a point of saying something about employer-based health care. This to me is a really interesting conundrum because, I mean, all of my life, all of our lives, that's really been the principal access point for health insurance. And there has been a discussion for some time about whether we should disengage insurance from work, in part because the portability of healthcare is seen as a value, right? There's a benefit to that. What do the economics of this look like? If you were somehow to be able to, and of course, a pandemic when so many people lose their jobs is a perfect moment to have this conversation, because again, if our uninsured numbers have spiked up, it's in part because people lost jobs and therefore lost insurance. How does that change the economic conversation? If you did
currently, most employers shop for one particular insurance plan from one company. Like we're going to cover all of our employees with Aetna or United Healthcare. And you might be able to choose between sort of a nice PPO plan and an HMO plan, but there's just not a lot of competition. And so that locks the company into a particular high price. If you could disconnect that and say, for instance, have an exchange where all employees could choose from the packages being offered by multiple insurance companies. Insurance companies would hate that, by the way. You would have more competition and you could potentially lower costs. I mean, the way you do it now, the employer buys from one insurer just because they can say, look, I'm sending you a bunch of customers, so you give me a price break. All right. If you could do that, the problem is it's politically harder to do then you have something that works much better in terms of lowering costs and giving employees options. I think that employers tend to choose packages that are high cost, that satisfy their highest salary workers,
Right.
and just say, just forget what happens with, our lowest wage workers. But we just want to make sure that our highest paid employers are comfy.
Right. And the reality is healthcare, like everything else, is not a one size fits all proposition. And if you're a company, you're often forced, as you say, in the position of looking for a plan that is for everybody, but not everybody along the income continuum or the life experience continuum might benefit at the same place, right?
Exactly. The reason why so many people are uninsured is because health insurance is just too expensive. And there are not enough options for some of these lower income people to choose something that's better priced for them.
Right. To raise Perryman's point of a moment ago, Dr. Ho, about rural hospitals, we know that over the last decade, more rural healthcare providers in Texas have closed than rural providers in any other state. We have a legitimate rural healthcare crisis, or we did before the pandemic. It's only gotten worse over the last year. Do you agree with Dr. Perryman that the economics of some form of expansion or some change in the way we look at healthcare will benefit and possibly turn the corner for rural healthcare specifically?
Absolutely. We need to figure out ways to get, the large hospital healthcare system thing that works in the major cities just doesn't work in our rural communities. So we have to figure out ways to give better support in terms of government support for these places, and also something in the private market that works better for those communities.
Got it. All right, Senator Johnson, this is the time during every conversation you and I have where I pronounce your optimism adorable and naive. Here you are in a legislative session in which Republicans have the majority in both the House and the Senate. You have a Republican governor. The point of view of the people in leadership at the state level on this question has been pretty clear. I went into journalism not to do math, but like Tom Luce, I can count. I can't get to 16 in the Senate. I can't get to 76 in the House. What am I missing? What are the political realities of the session? And why am I wrong and you're right?
Evan, because you're looking at this like people are looking at global warming. If you look up there and say, I'm trying to drive the boat to the safer place, and you do a little flyover and you say, hey, look, ice, just like there's been for 1,000 years, can't get there. And what you're not seeing is that the ice is melting right exactly now. The fact that I'm sitting here on this panel with Ray Perryman and Vivian Ho and Tom Luce and Charles Miller says that it's a different environment. We have a completely different environment in a lot of ways. The other thing that I think Charles said that was so important is there's a way that we can do this that isn't the plain old traditional Medicaid expansion. And that involves elements of copays and premiums and healthy behaviors. And it involves 90-10. It's free. People didn't know it was free. They didn't know that you could do it on a basis of revising and improving the Medicaid system. And as for leadership having taken positions against this in the past, that is the past in the past environment. And in the interim, what has happened is we have had dozens upon dozens of reforms to improve our Medicaid system. So if we were afraid previously of expanding a broken system, we got a pretty good system right now, and it's a Texas system. There is a way to get there. And as Tom was saying, there under the surface, as the water's warming up, there are countless conversations. I assure you, the legislator, without disclosing any private conversations, is looking for a way to do this. And the way to do this is the way that 2036 was just describing. That's why I have a bill that draws upon states like Indiana, that introduces things that have been embraced by Republicans across the country, that is working very, very well. The last thing is the economics of this. I don't need to explain to everybody how it actually saves money for the state or makes money for the state, because I've got far more esteemed people than me who have already explained it here on this phone call. What's also lurking right now is another possibly $5 billion from the federal government if we expand. I expect to see that decision come down in like a couple of weeks, or that to pass. How much, for those of you who philosophically disagree with this, how much money are you going to reject based on your desire to not provide health insurance to people?
Senator, hasn't the argument been, though, that the amount of money we get from the federal government is time limited, and that eventually we're going to be stuck with the bill for the additional cost of providing health care? That's been one of the talking points since this conversation began under Governor Perry.
Yeah, and people are saying that a lot less right now because they realized they were wrong. There was this perception inside and outside the building that it was going to drip down to zero. No, it doesn't. It's there in statute. Could it blow up? Look, everything could blow up. We could stop funding our schools. We could stop building highways because the federal government might stop doing it. But the fact is, the Medicaid expansion portion of the federal budget is about 1%. It's extremely visible. If you were to cut that, it would be political suicide in 38 states in this country. So if you're going to go, worried about the national debt or worried about the federal government cutting us off, it doesn't make a whole lot of sense. Finally, on that subject, right now we're doing pretty poorly. We have an opportunity to draw down federal dollars to do better. Are we going to reject that because someday we might have to go back to the bad program we have right now? I don't think that makes sense either. Now, but your question, Evan, is not whether it makes sense. The question is, can we move it through the legislature?
Sure. Yeah,
right?
Well, it is, and I want to ask about that in a second, but I do want to raise one more thing on this before we get to that, and that is, we all know that right before the Biden administration came into office, the state of Texas requested an expedited waiver of the 1115 waiver, right? And there are some who believe cynically that the state of Texas did so to hold off this Medicaid expansion conversation entirely. If we got an 1115 waiver for some period of time, that would make a discussion of a Medicaid expansion in Texas unnecessary. We actually got a 10-year waiver. I believe we didn't even ask for 10 years, but we got 10 years. They got it in right under the wire. The question is, does the expanded 1115 waiver make this conversation and any conversations that you'd be having at the Capitol moot? There are some who believe that it does.
Absolutely not. It was a good thing that we got that non-expansion. There's two kinds of 1115s. There's non-expansion 1115s and there's expansion. What Governor Abbott was successful in doing was going to the Trump administration and saying, hey, please continue to provide us financial support for our uncompensated care because we have so many uninsured people that we're going to need it. Well, guess what? If we expand Medicaid, we're still going to have 4 million people who are uninsured. We're going to need that, so I'm glad we have it. Meanwhile, it was rushed through contrary to the guidelines of CMS itself, and there's some question as to whether or not it's even going to stand up. I hope it does. It's good money, but it insures how many people? 0. It provides no insurance to any Texan. It does not moot this conversation. It's a nice thing to have a backstop, but we have got to move forward. And the only way that can moot this conversation is if no one talks about it. So we need the press. We need every person out there. We need our experts. We need our legislators letting us know that the problem isn't solved. We have just put we've just got a backstop on a different problem, but let's go after the stuff.
Ray Perryman, let me ask you about the thing that Texans hate the most in the world. Do you know what that is?
My guess is anything Washington does.
Well, actually, I was going to say California. I like your answer.
That's right up there.
but I like my answer better. So, we hate to compare ourselves to California, our mortal enemy, but actually we love to compare ourselves to California because we mock California incessantly. Here are two statistics. Uninsured children. The population of Los Angeles County is 2 times the population of Harris County and 4 times the population of Dallas County. But LA County has only a 4% uninsured children rate. Harris County has 15%. Dallas has 17%, despite the population difference. Right. Overall, Texas has 17.5% of its children uninsured, as you heard Charles Miller say. California has 4.4% of its population of children uninsured. Is there a comparison, again, from an economic standpoint, your bailiwick, your wheelhouse, Dr. Perryman, on Texas versus California? Because often we say we have so many embedded economic advantages over California, but somehow California seems to be doing at least this piece better than us.
Well, I think California has a different philosophy about how to deal with healthcare and a lot of other social issues.
Right.
We have, and it shows up here. But I mean, think about what that means. Think about what that means for a second. That means that 4 times the percentage of kids in our large counties are not going to be as healthy as they start attending school. And as they move forward through their education process, that means they're not going to perform as well in school. That means they're going to have less productive lives. That means they're going to be a bigger drain on the social service system or a smaller contributor to the tax system and the growth of the economy going forward. But there are very, very real implications of these things that don't stop on the legislative calendar. And so, I mean, again, that is one of many reasons. And as Nathan said, if the parents have insurance, they're more likely to sign up the kids. Frankly, we've made it pretty cumbersome to sign up kids in Texas. There's some things we could do to make, there's a lot of things we could do along the way, but it's going to take a belief that we should be trying to provide a sustainable health system, which for many, many, many reasons, but one that may resonate with some folks is whatever you think about health, it's absolutely essential for long-term economic growth. You cannot have long-term sustainable economic growth with the health system we have today.
Dr. Ho, you heard Charles Miller in the first part of this hour talk about the importance of price transparency. You know, I think for a lot of people who are thinking about this issue, the concept of price transparency causes them to go gray. That's not something that they get emotional about or they feel personally connected to. But there's also something undeniable about the fact that if you have a better sense of what things cost, it might actually affect consumer behavior. Can you talk about the importance of price transparency in this conversation?
Right. You know, they're actually good podcasts, and they talk about how we need to have price transparency. And it's very important for people who suddenly face an extremely expensive procedure and can't afford it. They've got a high deductible health plan. They're going to have to pay out of pocket. And then other people just, why does this affect me at all? Well, right. What happened if you took those people and the thing is, it's, you don't feel like you have to do many people don't feel like they have to do anything, even if they see price differentials between where they want to go and the alternative place because it's covered. Right. But we need to start considering changing plans, and so that there is a reward to consumers for actually price shopping. And and many employer-sponsored plans don't do that. And then if you have a rich, the copay system, even under Medicare and Medicaid, that happens. And so if we could have sort of shared savings, so you tell people, and if you go to the lower cost provider, we're actually going to rebate you some of those savings.
Right.
Then you have a completely different system. But the research right now shows that once you introduce price transparency, that's great. But in most cases, it doesn't lead to a reduction in expenditures.
Okay. We have about 2 minutes left, Senator Johnson. I want to ask you one final question here. We've talked a little bit about the political realities, and you've made your case for why maybe I and others are not seeing the environment in the building at this moment the way we ought to. But let's leapfrog that. What would you think about taking the question of Medicaid expansion in Texas, as has happened in other states, to the ballot, to the voters? The Episcopal Health Foundation study in 2019 found that 64% of Texans favor expanding Medicaid. 71% have a very or somewhat favorable view of Medicaid expansion. Today's University of Texas Tribune poll, what we published today, as if we planned it for this conversation, 49% of Texans believe that the state spends too little on the uninsured. What about that? If we believe that the voters should have their voice in this conversation, why not take it to the voters?
It's an excellent idea. And I filed that bill last session and I filed it this session, but It's not going to pass. We're going to need 2/3 of the legislature to be able to put it to the voters. If it went to the voters, it would pass. It's actually a much smaller lift to get a majority of the House and Senate to do it. And I think we've really at a moment right now when we're getting close. Look, it's silent right now out there. We've got one Republican who's filed anything on Medicaid expansion. You're going to see more Republicans in the House, eventually in the Senate, who come out in support of this. And leadership is confronted right now with a way to do it that works for Texas. And I think we're at that moment. The fact that we have Tom Luce and Charles Miller out here presenting objective data with the specific objective of bringing everybody to the table says that we're close. We're really close.
It gives you optimism.
It gives me a credible basis to form a belief that we're going to get there. This is not optimism. This is reason. This is rationale. This is a conclusion. And this is based on conversations with people that are going on this morning before I got on this phone call. Stuff is moving.
Anytime that we're talking about reason and rational behavior in the legislature, I want to stop right there because it makes me feel good about the future. Okay, Dr. Vivian Ho, Dr. Ray Perryman, Senator Nathan Johnson, thank you very much. Let me toss back to Jamie at Methodist Healthcare Ministries. Thanks so much for having us.
Well, what a fantastic discussion today. Thank you, Evan, for moderating today's discussion with our outstanding panelists. I want to thank all the panelists. You were incredible. On behalf of Methodist Healthcare Ministries, I'd like to close the session asking viewers to join us in a call to action. We find ourselves in the middle of our 87th legislative session in Texas, one that is certainly unprecedented as we battle to bend the curve on this healthcare pandemic. This is the time to act and ready ourselves and our communities for the next health emergency, the next natural disaster, or economic turndown, because there will be one. So join us in reaching out to your state House and Senate members. Please call them, send letters, emails, contact them through social media. Ask her or him to approach the issue of healthcare access with new eyes and to work this session towards a meaningful solution that will have a lasting impact for working families. Secondly, follow Cover Texas Now, a funded partner of Methodist Healthcare Ministries, to get information about their upcoming March 5th virtual Medicaid expansion advocacy day. And then finally, please join the Southerners for Medicaid Expansion Coalition to reach out to Congress and urge them to take action that will help Southern states secure health coverage for millions of uninsured families. I want to thank you for joining us today, and thank you in advance for taking action and making a difference for the people of Texas. Thank you so much, and God bless.